Hello, everyone, and welcome to today's lesson on seizure management in the emergency department. So we're going to talk about all kinds of seizures here today. Specifically, what do we do when they roll through the door of the emergency department? There are some great in-depth lessons on seizures here in the MedSurg Neuro units on nrsng.com. So if you guys want to get more into the how and the why of seizures, go check those out. So what are some of the causes that may present seizures to us? Obviously, there are seizure disorders like epilepsy, trauma, specifically head injuries, can cause seizures. You ever see those movies when the guy gets hit in the head and then he starts convulsing? That's actually based in some medical science. Hypoxia and stroke can both prevent oxygen from getting to the brain, causing seizures. In addition to oxygen, the brain really likes glucose and salt. Any alteration of those, more seizures. And then there's the concern of infections like meningitis or encephalitis or brain abscess. I think that's spelled right. And these can all cause alterations in brain chemistry leading to seizures. Now, there are some special patients we need to keep in mind. Pregnant females, they can suffer a condition called eclampsia, in which they have an emergently elevated blood pressure, which leads to seizures. Alcohol withdrawal can lead to the DTs, or delirium tremens, and seizures. And certain toxic recreational drug overdoses can cause seizures as well. So the first type of seizure, and the one we all know and recognize right away, is that tonic-clonic seizure, also known as grand mal seizures. These are characterized by a loss of consciousness and a loss of muscle tone. They're also seen with those kind of extensor muscle spasms in the extremities, those contractions, those convulsions. This is that traditional appearance that we all know and love, that we all see on TV, that we've all seen and we describe as a seizure. The major concern here is the fact that they are not breathing adequately, if at all. The traditional grand mal seizure is usually followed by a postictal phase, which we'll talk about. Partial seizures are a bit different, known as focal seizures, Jacksonian march, psychomotor, or minor motor seizures. These don't present with the full body spasms that the tonic-clonic seizure is. They're usually unilateral, focusing, just on the arm or the leg, and they can range from simple to just tingling in the muscle, or the full-on contraction to one or several areas of the body. Even with these contractions, there is no level of no loss of consciousness. The patient's fully aware of the situation. Many times, these resolve on their own, and if they last less than 5 minutes, we typically don't medicate them. Now, I also want to mention complex partial seizures here. These are characterized by an alteration in the level of consciousness. The patients don't lose consciousness, but they may not be aware of what's happening. They typically look kind of zoned out, staring off into space. They get kind of a zombie look to them. You can see repetitive lip smacking or swallowing. These patients can actually even move and walk around, but the movement isn't purposeful. Now, these usually last from about 30 seconds to 2 minutes. And when the seizure is done, they also can experience that postictal phase with some confusion and sometimes no recollection of that period of time in which they were having the seizure. So febrile seizures are caused by just that, a febrile or fever. The rapid rise in body temp, you're going from like 98 to 104 very quickly. It causes a short circuit and a seizure. These are more common in infants and pediatrics. That is my horrible excuse for a baby. The main treatment is aimed at lowering the body temperature and keeping the patient safe. Now, febrile seizures, while they may be indicative that the kid could have another febrile seizure, it's not really a sign of a seizure disorder. And a lot of parents get very concerned about that. They think, oh my God, my baby had a seizure. He's going to have seizures his whole life. That's not necessarily true. He may have another febrile seizure, but it doesn't mean he has epilepsy. Status epilepticus. This is where things can go bad. Status is considered consecutive seizures with no return to normal. Basically, before the postictal phase ends, before they come back to normal, they seize again. It can also be classified by a seizure lasting more than 5 minutes that isn't resolved by the usual methods. You start giving meds and they keep seizing. This is a definite medical emergency, and I want you to think about why. So we talked about the tonic-clonic seizure that can result in those abnormal respirations or apnea. So think about a patient who can't adequately breathe for 5 minutes. Think about the lack of O2 that they're getting. I also want you to think about the energy being burned by 5 continuous minutes of involuntary muscle contractions. These patients can suffer from acidosis, hyperglycemia, hypercalcemia, muscle damage leading to rhabdo, and eventually, if we don't correct these things, death. So as with everything, documentation is key. One way to help document seizures is by using the cold mnemonic. C is for a character, what type of seizure occurred, onset, when did it start? When did it start? Location, where was the seizure? Not like did they fall down in their home, but the location of what seized, their arms, their legs, where on the body. And duration, how long did the seizure last, which is very important. If you document those 4 things, you should be covered. And I'll give you an example. So, patient had a tonic-clonic seizure at 13:29. Patient was lying in a monitored bed watching television when the seizure activity began. Seizure involved both upper and lower extremities and lasted approximately 45 seconds. We covered all 4 things. We document appropriately, and it basically describes what happened when the patient had their seizure. Now, of course, to answer the question we've all been asking, what do we do for these guys? Well, as always, we keep the basics in mind. Airway, breathing, circulation are our priorities. That's nothing new. We want to get on the non-rebreather mask or NRB. The nice thing about that is it usually has a strap which we can attach to the patient. So if it becomes difficult to use a bag valve mask for somebody who isn't ventilating well because they're actively seizing. But, if someone's in status, we may need to perform what's called rapid sequence intubation or RSI, where we're actually going to paralyze them so we can insert an airway and then breathe for them. Now, while making sure they're breathing, which, is kind of important, we also want to provide for their safety. So these patients have no control over their spasms, and they could be hitting anything, smacking against the side rail of the bed, against the floor, wherever they are, they're going to be hitting stuff. Now, many facilities have protocols on seizure precautions. Things like padding the side rails of the bed with pillows or blankets. I would just check with your facility on what they use as seizure precautions. There should be something. Now, we want to stop the seizure. And for that, we're going to use benzos or benzodiazepines. We're going to push IV meds such as Ativan, Valium, phenobarb. Now, I wouldn't recommend using them all at once, but we may try each one if the prior one isn't working. So, quick story. So a mother brings in her 21-year-old son after having 2 seizures in the field, lasting about 2 minutes each. When he gets to us, he's awake and alert. Now, about 10 minutes after getting to us, he has another small seizure that we halt with 2 milligrams of Ativan IV. We monitor him through the postictal phase, he becomes normal, and we leave the room. About 15 minutes later, we hear the mother yelling for help, and when we enter the room, we see the patient on his side, pants around his knees, and a syringe like this one, sticking out of his rectum. Now, our first response was, as I'm sure would have been yours, what did you do? Now, I didn't know it at the time, but apparently rectal Valium or rectal diazepam can be given to caregivers to be administered in the event of an emergency. Syringes just like this one. This mother, in a panic because no one was in the room, chose to act first rather than call for help. And we, of course, asked her politely not to do that again, as she was in a building filled with medical professionals. And I, of course, learned something I didn't know. Moving on. Once we stop the seizure, we want to prevent more from occurring, so we might start an infusion of an anticonvulsant like Dilantin, Cerebex, or Keppra. And any of these can help to prevent seizures, and it's going to really be the doc's discretion as to which one we hang. So after stopping the seizure, we want to provide some metabolic replacement. Very commonly, our patients might become hyperglycemic. They're burning off glucose as they seize. And to correct that, we're typically going to give an amp of D50. One thing to be aware of, if we have an alcoholic patient, you want to make sure to give an amp of thiamine IV before administering the D50. And why? Well, chronic alcoholism can actually cause alterations in the blood-brain barrier. Pictured here, brain, blood, barrier. Okay. The rapid influx of glucose from an amp of D50 can actually pass through the weakened blood-brain barrier too quickly and cause a rebound encephalopathy or cerebral edema, which is known as Wernicke-Korsakoff syndrome. The easiest way to prevent this is to give that amp of thiamine, which strengthens the blood-brain barrier and prevents the rapid absorption of that glucose. It doesn't prevent it, it just slows it to a manageable speed and prevents that rebound encephalopathy. So make sure to give that thiamine before you give the D50 if you think they're an alcoholic. So after the seizure has ended, the patient's going to be in their postdictal phase. Now, they're usually going to be confused, and it's really here, it's our job to provide for their safety. I want you guys to be aware these patients can be very agitative and even combative, which can manifest in physical violence. Perhaps not to the level we see here, hopefully, but I got to be honest, I can't say I haven't gotten kicked by a seizure patient or two in my time. Now, remember, if this patient becomes a little rowdy, they are completely unaware of what they're doing and they can't control it until the postdictal phase passes. Just make sure they don't hurt themselves or anyone else like this poor guy right here. He is definitely going to feel that in the morning. So, some concepts. We want to use our clinical judgment here. It's very important, not just in treating the tonic-clonic seizures, but in recognizing those partial and complex partial seizures. Obviously, with our more severe seizures, cognition is going to be impaired both through the seizure as well as for a period of time afterwards. And as always, guys, provide for our patient's safety. Use your facility-specific seizure protocols. A few of our key points. First thing is to identify the seizure. Tonic-clonic is easy, but some of those partial seizures may be harder to identify. I want you to document using the cold mnemonic, medicate them to stop the seizure and then prevent further seizures. I always want you guys to avoid that tunnel vision. ABCs always, because it can be overwhelming when someone is in that full tonic-clonic seizure. But remember, this guy can't breathe, okay? And as always, make sure you're keeping your patient safe both through the seizure and after. Once again, guys, thanks for joining us. Please check out all our other emergency medicine lessons here on nrsng.com. And as always, happy nursing.